Hello everyone, it's Dr. Yazdani here. We discussed acid base and blood gas last week. If you have missed that video, pause here and take a look. The link is in the description. Today we're going to cover some of the other important components of blood gas. One of the most important values, which is often hemolyzed to our despair, is potassium. Insufficient sample or poor technique. A poor technique may also give you a spuriously high potassium. If you get a potassium reading that is very high, like 7, you have two options. One is to gamble and assume that the lab potassium will be normal. Option 2 is to repeat the gas. Remember, we're not in the business of assumptions. We're meant to protect lives with solid tests. If a patient has been unwell enough to have had blood tests done, then you should always assume the worst until proven otherwise. This way, you won't go wrong. So, if you have the slightest reason to believe your patient may have high potassium levels, get a repeat gas and, of course, an ECG. We covered PCO2 in the previous blood gas video. If your PCO2 is high, even on a VBG, you need to assess your patient's breathing. Is this a COPD patient who's receiving too much oxygen? Things like that. The PCO2 may range anywhere from 5.5 to 6.8 on a venous sample. Base excess is another blood gas parameter that might be ignored. It may be shown on your blood gas as base B or base ECF. B stands for blood, ECF for extracellular fluid. They're pretty much similar. Your base excess increases in metabolic alkalosis, where your body produces too much bicarbonate. Base excess decreases or becomes more negative in patients with metabolic acidosis, like DKA. Sodium is one of the important electrolyte readings on your blood gas. It usually correlates well with your lab sodium, and as long as you don't get it from the same arm that's receiving the saline drip, it is more error-resistant, if you like. If you notice a severely low sodium and the doctor has prescribed a bag of stat saline, don't hesitate to warn them of the risk of rapid sodium correction in a hyponatremic patient. Low sodium values are seen in a variety of clinical scenarios, which are beyond this talk. However, in patients with high blood sugar, sodium levels may be spuriously low. This is called pseudo-hyponatremia, something to bear in mind. Patients with extremely low sodium levels are at high risk of hyponatremic seizures. If they do seize, sodium may have to be corrected more rapidly. Higher sodium levels are seen in dehydration. There's not a lot of complexity to it, really. It's usually treated with 5% glucose. Some even use normal saline. Low calcium levels are very frequently seen in patients with vitamin D deficiency, a very common cause, especially in areas that don't enjoy much sunshine. Hyperventilation can acutely reduce your calcium levels. Low calcium levels can cause hand spasms. High calcium levels, on the other hand, can affect the way your heart works and may require urgent treatment, regardless of the cause. Get an ECG and let the doctor know. Moving on from electrolytes, blood glucose is another reading which is of paramount importance in the workup of patients with reduced GCS, seizures, diabetes, and of course, in nonverbal patients and elderly fallers. Make sure you don't overlook this important reading. Lactate is an important indicator of your state of perfusion and oxygenation of tissues. Increased lactate readings are usually associated with greater severity of disease, be it sepsis, aortic dissection, DKA, ischemic colitis, or other conditions. Some medicines like metformin or salbutamol also tend to increase your lactate levels. We all know the significance of hemoglobin. What we may forget is that hemoglobin levels may appear normal in a patient with acute hemorrhage. Therefore, don't use hemoglobin to assess the hemodynamic stability of a patient with an acute bleed. Methemoglobin is one of those readings which is often overlooked. High levels are commonly caused by exposure to certain chemicals and medical substances, such as benzocaine, exhaust fumes, herbicides, and pesticides. In the emergency department, we occasionally come across elevated methemoglobin readings in young patients who have used recreational drugs containing nitrites, gold or poppers, for example. These patients may require urgent treatment, so don't skip methemoglobin next time, and make sure your doctor doesn't either. The last blood component we have time for is carbon monoxide. I cannot emphasize the importance of this parameter in unwell patients attending your department. Carbon monoxide poisoning is a potentially lethal condition that is seen in patients exposed to fires, faulty boilers, or exhaust fumes from cars in closed spaces. Unfortunately, these patients will not usually be able to tell you what they've been exposed to. They may attend your department with vague flu-like symptoms, headache, dizziness, vomiting, chest pain, or confusion. If you get more than one patient from the same household, have a high index of suspicion and double-check their CO levels. That said, carbon monoxide levels can go all the way up to 9 in heavy smokers. That's all we have time for today. Until next time, be safe and thank you for watching.